Hello, I'm Nusha Godse. I'm an associate professor of medicine in the Department of Cardiology at Mount Sinai, and I'm going to be doing a talk on cardiovascular management, cardiac and perioperative risk assessment. Um, so let's get started. So there are over 300 million surgeries worldwide per year. Patients are presenting with increasing ages, increasing comorbidities, and so they are at increased risk of perioperative cardiovascular events. There are multiple tools at our disposal, and now newer tools such as biomarkers with proBNP and high sensitivity troponins that allow us to reduce the perioperative cardiovascular risk for patients. Of note, preoperative interventions are rarely necessary unless this intervention would have to take place anyway. The preoperative evaluation is an assessment of the patient's current medical status. It allows us to make recommendations regarding the patient's risk of cardiovascular events and management of those risks. We develop a risk profile for the patient, and this allows all the physicians involved, the primary care doctor, the surgeon, the cardiologist, as well as the anesthesiologist, to make decisions that could minimize short and long-term cardiovascular events. The goal is to evaluate the patient and to do the most appropriate testing, and of course, avoid inappropriate testing in order to evaluate the risk and then plan strategies of care and treatment and optimize the patient for short and long-term cardiovascular risk. The last set of preoperative guidelines published in the United States are from 2014 and are reviewed and updated annually. The American College of Cardiology or the American Heart Association guidelines for preoperative cardiovascular evaluation for non-cardiac surgery are based in large part on observational or retrospective studies and or from extrapolation from knowledge of management of cardiovascular disorders in the non-operative setting. There are very few prospective or randomized studies performed to establish the value of different treatment and options in this cohort. In general, indications for cardiac testing and treatment are similar in those in the non-operative setting, but depend also on other factors, such as the urgency of the surgery, the patient's risk profile, and of course, specific surgical considerations. Coronary revascularization is limited to a small subset of very high-risk patients. Recommendations in the guidelines are divided into classes. Class 1 recommendation, where there is evidence and general agreement that the procedure or the therapy is useful and effective. Class 2 recommendations, there is conflicting evidence and or divergence of opinion about the usefulness or efficacy of the procedure or therapy indicated. 2A, the weight of the evidence or opinion is in favor of the procedure or therapy. 2B, that usefulness or efficacy is less established. Class 3 recommendations are evidence or agreement that the procedure or therapy is not useful or effective, and in some cases may actually cause harm. Many patients undergoing major non-cardiac surgery are at increased risk of cardiovascular events. And it's widely understood that cardiac patients are particularly vulnerable to adverse events in the perioperative period. A combination of catecholamine surge, inflammation, and thrombosis are the perfect storm for cardiovascular injury. The risk is related to both the patient characteristics as well as surgery-specific characteristics. Identification of increased risk provides the patient and the physicians involved, the surgeon, the anesthesiologist, and the cardiologist with information that helps them better understand the benefit to risk ratio of a procedure and may subsequently lead to interventions that decrease the risks of the same said procedure. In the United States, the incidence of perioperative major adverse cardiovascular and cerebrovascular events, or MACE, is defined as in-hospital all-cause death, acute myocardial infarction, and ischemic stroke. And this occurs in about 1 out of every 33 hospitalizations for non-cardiac surgery. These events are most frequently noted in those undergoing vascular, thoracic, and or transplant surgeries. Surgery-specific risks are related to the type of surgery and the degree of hemodynamic stress that's associated with the procedure. Surgery-specific risk can be high, intermediate, or low level of risk. The highest risk surgeries that carry a greater than 5% reported cardiac risk in general are those that are emergent major operations, especially in the elderly, aortic and other major vascular surgeries, peripheral vascular surgery, and those surgeries with anticipated prolonged times and large fluid shifts and and blood loss. Intermediate surgeries carry a greater than 1 but less than 5% cardiac risk in general, and those include cardiac endarterectomies, head and neck surgeries, intraperitoneal, intrathoracic surgeries, orthopedic surgeries, and prostate surgeries. And finally, low-risk surgeries, or those that carry a less than 1% cardiac risk, include endoscopic procedures such as colonoscopies, superficial procedures, dermatological procedures, cataract surgeries, and breast reduction surgery. In the initial evaluation, the history, physical exam, and the electrocardiogram are important to identify potential serious cardiovascular disorders, including coronary disease, prior myocardial infarctions, angina, congestive heart failure, patients with symptomatic arrhythmias, and of course the presence of pacemakers or defibrillators. Patients with underlying cardiovascular diseases, including peripheral arterial disease or stroke, have an increased risk of perioperative cardiac complications compared with those patients without extant atherosclerosis. Among patients with cardiovascular disease, those with coronary disease and congestive heart failure have the highest risk of perioperative cardiac complications. In addition to these, patients with a history of cerebral vascular disease, with a history of chronic renal insufficiency with creatinines greater than 2, and those diabetics who are insulin dependent are at an increased risk of cardiovascular morbidity. Major predictors of increased perioperative cardiac risk are unstable coronary syndrome, such as patients with an acute or recent myocardial infarction less than 7 days to 1 month prior to surgery, and those with Canadian class 3 or 4 unstable or severe angina, patients with decompensated congestive heart failure, patients with significant arrhythmias, such as high-degree AV block, symptomatic ventricular arrhythmias, and supraventricular arrhythmias with poor heart rate control, and of course, patients with severe valvular disease, such as severe aortic stenosis. Those patients who have sustained a recent myocardial infarction are more likely than controls of having recurrent post-procedure myocardial infarctions. The risk diminishes with time from onset of myocardial infarction to the date of surgery. And based on ACC/AHA guidelines, in patients who have not undergone revascularization post-MI, a period of at least 60 days is recommended prior to undergoing non-cardiac surgery. Intermediate predictors of increased perioperative cardiovascular risk are Canadian class 1 or 2 mild angina, a previous history of myocardial infarction, either by history or pathological Q waves, patients who have had a history of prior congestive heart failure or have compensated congestive heart failure, diabetics, especially those who are insulin dependent, and patients with chronic renal insufficiency with creatinines greater than 2. Minor predictors of increased perioperative cardiovascular risk include advanced age, patients with abnormal electrocardiograms, such as those with LVH, left bundle branch block, or nonspecific STT abnormalities, patients with rhythms other than sinus rhythm, especially atrial fibrillation, patients who have a low functional capacity or less than 4 metabolic activities, those with a history of cerebrovascular accidents, and patients with uncontrolled hypertension with blood pressures greater than 180 over 100. The postoperative state, as I've already stated, is characterized by catecholamine and cortisol release, inflammation, and thrombosis. Tachycardia and hypertension can lead to plaque rupture or thrombosis, causing a type 1 myocardial infarction, while demand ischemia or type 2 myocardial infarctions can result from tachycardia, hypotension, anemia, or hypoxia. Although most risk prediction models concentrate mostly on coronary artery disease, patients with congestive heart failure may be at the highest risk of morbidity and mortality after major non-cardiac surgery. Compared with coronary disease, those with congestive heart failure are at high risk immediately postoperatively, but also up to 30 days post-surgery. Patients with severely reduced ejection fraction or an LVEF less than 30% this is an independent predictor of adverse cardiovascular events. And long-term mortality correlates well with decreasing ejection fraction. All patients scheduled to undergo non-cardiac surgery, as mentioned before, should have an assessment of the risk of cardiovascular perioperative cardiac events. The purpose of this assessment is to help the patient and the healthcare providers weigh the benefits and risk of surgery and to optimize the timing of that surgery. On occasion, the risk assessment will uncover undiagnosed problems or suboptimally treated prior conditions that need attention. The clinician uses the information obtained from the history, the physical exam, and the type of surgery in order to develop an initial estimate of perioperative cardiac risk. The American College of Cardiology and the American Heart Association guidelines outline a stepwise approach to the pre-op assessment of cardiovascular risk. These risk models estimate the risk based on information obtained from the history, physical, EKG, and the type of surgery as previously mentioned. When assessing preoperative cardiac risk, we use either the Revised Cardiac Risk Index, RCRI, also known as the Lees Index, or the American College of Surgeons National Surgical Quality Improvement Program Risk Model Calculator, or the NSQIP. The RCRI is much simpler and has been widely used and validated over the past 16 years. The NSQIP calculator is much more complex. It uses calculations with requiring on-tool lines and has yet to be validated in all populations. The RCRI is straightforward, and it includes 6 independent predictors of major cardiac complications. High-risk surgeries such as suprainguinal vascular surgeries, intraperitoneal surgeries, and intrathoracic surgeries. Patients with a history of ischemic heart disease, those with a history of congestive heart failure, patients with known cerebrovascular disease, diabetics who are on insulin, and patients with chronic renal insufficiency with creatinines greater than 2 mg per deciliter. The NSQIP risk calculator takes into account age, creatinine higher than 1.5, the patient's preoperative functional status, the American Society of Anesthesiology class, and the surgical site. Other things that need to be considered in the perioperative period include atrial fibrillation. A retrospective administrative database study demonstrated an association between a history of prior admission for atrial fibrillation and postoperative complications. The risk associated with AFib was actually higher than that associated with the diagnosis of coronary artery disease in this database. Obese patients are also at increased risk of adverse cardiovascular events at the time of non-cardiac surgery. However, obesity has not shown to be a predictor independent of end organ damage. And so the issue of whether the preoperative approach to these patients should differ from that of the general population is still uncertain. Patients with hypertension need to be treated. Those with blood pressures greater than 180 over 100 need to be controlled prior to surgery. An effective regimen for blood pressure should be initiated a few days or weeks prior to surgery. Short-acting agents may be needed in cases of more urgent surgeries. And of course, defibrillators and pacemakers need to be addressed. Especially important to address is whether the patient is pacemaker dependent. Electrocautery used at surgery can affect pacemakers and defibrillators, and ICD devices should be programmed off immediately prior to surgery and then turned back on post-operatively. And while the defibrillator is off, and this is extremely important medico-legally, the patient has to be monitored constantly while that defibrillator is off. Patients with suspected valvular disease need to undergo echocardiography to quantify the disease severity, the ejection fraction, and the right-sided pressures prior to non-cardiac surgery. Those who meet criteria for valve replacement should be intervened on prior to elective non-cardiac surgery in order to reduce cardiovascular risk. Of note, based on the 2014 ACC/AHA guidelines, in those with severe but asymptomatic valve disease, especially regurgitant valvular disease, we can proceed with elective surgery at elevated risk with appropriate close hemodynamic monitoring perioperatively. However, of note, patients with severe AS have a 13% risk of perioperative mortality. And even in those with moderate aortic stenosis undergoing non-cardiac surgery, there is an increased 30-day mortality and post-op myocardial infarction rates compared to controls. Cardiac functional status or capacity, as determined by doctors assessing the patient with a brief set of questions, has been thought to be positively associated with postoperative outcomes. The functional status can be expressed in metabolic equivalents, where one metabolic equivalent, or one MET, is defined as 3.5 cc's of oxygen uptake per kilogram per minute, which is the resting oxygen uptake in a sitting position. The ability to achieve 4 METs is thought to be a good prognostic indicator. Indicators of functional status include the following: Can the patient take care of themselves? Can they eat, dress, or use the toilet? That gives them one metabolic activity. Can a patient walk up a flight of steps or a hill or walk on ground level at about 3 to 4 miles per hour? That's a 4 MET capacity. Can the patient do heavy work around the house, scrubbing floors, lifting or moving heavy furniture, climb 2 flights of stairs? That gives the patient 4 to 10 METs activity. And finally, can the patient participate in strenuous sports, swimming, singles tennis, football, basketball, skiing? This gives the patient a greater than 10 MET and very good prognostic activity level. Risk stratification models provide the user with the risk of cardiac complications in percent. For those patients at low risk or less than 1%, then really no further testing is indicated. With patients who are at a higher risk profile, the doctors, the caregivers need to ask the question whether further cardiac testing will change the management and hopefully improve the outcome for that patient. In most cases, the reason to perform additional testing will be based not on the desire to lower risk at the time of surgery, but rather just to lower long-term cardiovascular risk. That is, the patient should have additional testing done irrespective of the need for surgery. There are very few cases in which testing should be performed just for the purpose of upcoming surgery. Very high-risk patients, those with recent MIs, and that should say less than 7 days to 1 month post-MI, patients with unstable angina, those with decompensated heart failure, high-grade arrhythmias, or those with hemodynamically significant valvular disease, such as severe aortic stenosis, should be treated optimally. And possibly referred to either a cardiologist or electrophysiologist for management prior to surgery. Patients who require emergent or urgent surgery are at increased risk of perioperative outcomes at any level of baseline risk. In these cases, risk indices derived from elective surgery cohorts are not accurate, although they may provide an estimate of minimal risk. In the absence of preoperative assessment, because of the minimal time available prior to surgery, the clinicians, especially the anesthesiologists and the cardiologists, must be available post-operatively to help manage any possible cardiovascular complications in these high-risk patients. Stress testing with or without with exercise, with or without imaging, and pharmacological stress testing with imaging have been well studied in patients undergoing non-cardiac surgery. Although there's a clear relationship between the degree of myocardial ischemia found on stress testing and prognosis, there's no evidence that preoperative revascularization added to the recommended goal-directed medical therapy prevents or improves outcomes of surgery. If major risk is found, surgery should be avoided or deferred until that risk is corrected. Patients with intermediate risk should have deferment of surgery and risk stratification. Patients with minor risk should proceed directly to surgery without further testing. Resting echocardiography is not indicated in the perioperative setting unless there's another indication for this, such as to evaluate valvular function in patients with heart murmurs, to evaluate left ventricular ejection fraction in patients with heart failure or dyspnea of unclear etiology. And the timing of testing should, of course, be determined by the urgency of surgery. It's important to pay close attention to stress tests that are done and look for details and not just conclusions when looking at a stress test. The mode of testing is important. Those who can exercise have better outcomes than those with pharmacological stress testing, even if the pharmacological stress test is completely normal. The duration of exercise, the peak heart rate achieved, the EKG changes and timing of those changes, both with exercise and with pharmacological stress tests, the size of the defect, as well as the ejection fraction noted on the stress test, are all important to note. There is a clear relationship between the degree of ischemia and prognosis, but there's no evidence, again, that prophylactic revascularizations improve outcomes. Revascularization prior to non-cardiac surgery is only indicated if it's an otherwise class 1 indication for revascularization. So, as we mentioned before, only proceed with revascularization if otherwise indicated, and there is no routine revascularization that should be done in stable patients. According to some small observational studies, intervention on ischemic lesions may be beneficial. Most cardiologists do recommend intervening on critical lesions, but that may just be treating the cardiologist. There are no randomized trials documenting benefit in reducing post-operative events with prophylactic angioplasty or stenting prior to non-cardiac surgery. Based on the CARP trial or the coronary artery revascularization prophylaxis trial, the guidelines recommend against routine revascularization for stable patients. In this trial, in those patients with obstructive coronary disease, and the trial excluded those with left main disease, ejection fraction less than 20%, or those with severe AS. So in those with obstructive disease, absent these three things, revascularization had no effect on short or long-term mortality. However, subsequent reanalysis of the CART trial did show that in those patients who underwent CABG, coronary artery bypass grafting versus PCI, they had fewer MIs after vascular surgery, and this was attributed to a more complete revascularization. Also, those patients with left main disease did far better after revascularization. Currently, the guidelines recommend revascularization prior to non-cardiac surgery only if it's class 1, as I mentioned before, but again, does not recommend routine revascularization in stable patients. In those in whom non-cardiac surgery is required and they need to undergo PCI, one needs to decide on the relative risk of surgery and if discontinuation of antiplatelet agents is required. Studies show that the risk of adverse cardiovascular events following non-cardiac surgery is highest within the first 6 months after stent implantation, with stabilization of that risk at 1% after 6 months. The 2016 updated guidelines recommend elective non-cardiac surgery in patients treated with drug-eluting stents be optimally delayed at least 6 months after stent implantation and can be considered after 3 to 6 months if the risk of further delay outweighs the ischemic or thrombotic risks. The newer generation DES, or drug-eluting stents, seem to require shorter duration of dual antiplatelet therapy, or DAPT, as a result of lower rates of stent thrombosis in these newer stents. Elective surgery after DES can be considered after 6 months if the risk of further delay is greater than the expected risk of ischemia or stent thrombosis. And if PCI and surgery is indicated within 12 months, we can now use drug-eluting stents with dual antiplatelet agents, since these newer drug-eluting stents showed that it is feasible to go to the OR on dual antiplatelet therapy within days of implantation of stenting. So possible future biomarkers may be used. There are several meta-analyses that have shown that the use of proBNP or high sensitivity troponin may help to predict cardiovascular outcomes, such as postoperative non-fatal MI, death, and non-fatal MI at 30 days post-surgery. However, there's so much variability in the proBNP level, especially in various studies, and there is at this point no concrete level at which risk is considered to be too high to proceed to surgery. At this point, the ACC/AHA guidelines do not recommend use of these markers in the preoperative evaluation process, but I have no doubt that these will be coming up soon as recommendations. The following is a nice schematic going over the evaluation of the patient. So here we see the patients should be evaluated for risk for surgery. So if the surgery is emergent, you do the risk stratification by history and physical and go to surgery with close monitoring postoperatively. If the surgery is non-emergent and the patient is having an acute coronary syndrome, this needs to be evaluated and treated with gold medical-directed therapy prior to proceeding. If there is no acute coronary syndrome and the estimated MACE risk is less than 1%, then there's no further testing required and the patient should proceed to the operating room. If the patient is at elevated risk, so no acute coronary syndrome, but patient is at elevated risk, then an evaluation of the functional capacity needs to take place. If the patient's functional capacity is moderate or excellent, so greater than 4 METs exercise capacity, then no further testing is needed and the patient should proceed to surgery. However, if the functional capacity is poor or unknown, then you have to proceed with further testing. If the functional capacity is less than 4 METs, then testing would be taken if it would make an impact on further decision-making or perioperative cardiac care. If that further testing does impact management, then pharmacological stress testing, or more recently, CT angiography is undertaken. And if this is abnormal, then revascularization may take place and or goal-directed medical therapy, and decision may be made not to do surgery. If the patient with poor functional capacity, the impact of further testing makes no change on that decision making. So the patient has poor functional capacity, we have no impact with further testing, then either proceed to surgery or find alternative strategies, such as palliative care. Next is an evaluation of some of the medications that can be used around the time of surgery. The literature on beta blocker therapy is full of controversy. Among patients with an RCRI of 0 to 1, there has not been shown to be any benefit to treatment with beta blocker therapy, and there may actually be possible harm. In patients with a greater than 2 or 3 RCRI risk factors, there has been shown to be reduced 30-day mortality with the use of beta blockers. And the guidelines recommend considering beta blocker therapy in those with 3 or more RCRI risk factors, or at least an intermediate risk of myocardial ischemia seen on myocardial imaging testing. The beta blocker should be initiated in a reasonable time within, usually we prefer within a couple of weeks prior to surgery to ensure adequate safety and tolerability for the patient. Preoperative statin use is associated with significantly lower risk of all-cause mortality and cardiovascular morbidity and myocardial injury at 30 days. The pre-op guidelines recommend continuing existing statin therapy as long as there's no contraindications, and possible initiation of therapy in those undergoing vascular surgery or other surgeries that are elevated cardiovascular risk. Angiotensin receptor blockers and ACE inhibitors should be held 24 hours prior to surgery. So on the day of surgery, they definitely need to be held. For patients undergoing non-cardiac surgery, the rate of death, stroke, and myocardial injury was reduced when ACE inhibitors and ARBs were discontinued 24 hours prior to surgery. And this is felt to be an effect on blood pressure and renal function perioperatively with these medications. If patient has had a recent cardiovascular or neurological event, then ideally there should be a delay or deferment in the surgery. With bare metal stenting, which are now rarely used, 14 days of dual antiplatelet therapy is required prior to surgery. With drug-eluting stents, as we mentioned, especially the newer agents, we would wait at least 3 months ideally post-sirolimus stenting and 6 months post-paclitaxel stenting. For all neurosurgical procedures, we advise holding antiplatelet and anticoagulants as needed until they are cleared by the neurosurgeon. In those patients with mechanical valves and increased risk of thromboembolism, such as more than one mechanical valve, mitral valve, mechanical valve prosthesis, those patients with hypercoagulable states, previous thromboembolic events, such as a CVA or TIA, or an ejection fraction less than 30%, consideration has to be given to bridging with heparin or low molecular weight heparin. Otherwise, if a patient is at a high thromboembolic risk, the surgery would be delayed or limit the time off anticoagulation. Usually, we no longer bridge with heparin because of risk of bleeding complications. If Coumadin needs to be held or warfarin needs to be held, we hold it for 3 to 5 days prior to surgery and restart postoperatively with the ideally goal INR less than 1.5 checked on the day of surgery. The novel oral anticoagulants have to be held 2 to 3 days pre-op and restarted as soon as possible postoperatively, okayed by the surgeons. So the mechanical valves are the highest risk, especially the mitral valve mechanical prosthesis, those patients with hypercoagulable states, those who've had a CVA or TIA, and those with heart failure or LV ejection fractions less than 30%. These are really the only cohorts that still require bridging with heparin once the INR is less than 2, or the same with the novel oral anticoagulants. We usually use heparin, and this needs to be held 4 to 6 hours prior to surgery. And if low molecular weight heparin is used, the newest guidelines recommend holding 24 hours prior to the procedure. So in summary, all patients scheduled to undergo non-cardiac surgery should have an assessment of the risk of cardiovascular perioperative events. The functional status is an important determinant of that risk. Identifying risk factors from the history, the physical exam, the electrocardiogram, echocardiogram, as well as the type of surgery influences the risk of perioperative cardiovascular events. We use either the Revised Cardiac Risk Index, or the RCRI, or the LEAS Index as it's referred to, or the NSQIP, or the American College of Surgeons National Surgical Quality Improvement Program Calculator to predict or establish the patient's risk. We obtain an electrocardiogram in patients with cardiac disease, except those undergoing low-risk surgery in large part in order to have a baseline available should a post-op test be abnormal. And for patients with known or suspected heart disease, such as cardiovascular disease, significant valvular disease, or symptomatic arrhythmias, we only perform further cardiac testing evaluation, such as echoes, stress testing, or ambulatory monitoring of the heart rhythm, if it's indicated in the absence of the proposed surgery. So just one question to complete this talk. I have a 65-year-old patient who's pre-op for left total knee replacement with a history of a mechanical bileaflet aortic valve who is on warfarin. There's no history of atrial fibrillation, no history of strokes, and currently the patient is in sinus rhythm. Which of the following is the most appropriate advice with regards to anticoagulation regimen preoperatively for this patient? A, discontinue the warfarin 3 to 5 days prior to surgery and bridge with heparin before and after surgery. B, discontinue warfarin 3 to 5 days prior to surgery and restart on the evening of surgery. 3, continue warfarin preoperatively. Or D, continue warfarin, reverse anticoagulation with FFPs 1 hour prior to surgery, and restart that warfarin on the evening of surgery. So the answer, ideally, is B. Patients should discontinue the warfarin 3 to 5 days prior to surgery, which gets the INR ideally to less than 1.5, and restart the warfarin on the evening of surgery as long as there are no issues with bleeding. So although the risk of thromboembolism with a mechanical heart valve can be very high as 20%, the short-term risk of stopping anticoagulation is small. Given that this patient is not at increased thromboembolic risk, bridging with heparin is therefore usually not necessary. Thank you for your attention.